Hello, third-year students on your clerkships. This is Herb Chase welcoming you to the second session of Mechanisms in Practice. We hope you're having a terrific time. Lots of work, lots of learning. Well, this week is a continuance of clinical reasoning and the clinical reasoning thread. And we're going to visit two topics that are under the rubric of clinical reasoning: conflicts of interest and clinical informatics. We have two workshops scheduled for this week, and we're going to get a chance to discuss these topics in some depth. Let's go over the learning objectives. For the conflicts of interest workshop, we hope that after the workshops you'll be able to distinguish between a conflict and a conflict of interest, define conflicts of interest, and provide examples of the different kinds of conflicts of interest that arise in medicine. For the clinical informatics workshop, we hope that you'll be able to navigate some of the cool tools in the electronic health record, describe ways to guarantee patient privacy and security, and to describe how to formulate a successful data request for a scholarly project. Let's start our discussion with conflicts of interest in medicine. In the first session of Mechanisms in Practice in April, we focused on clinical reasoning, a composite of three key processes: diagnostic reasoning, clinical decision analysis, and test interpretation. We also went on to discuss that these processes were influenced by various cognitive biases which diminish the quality of our reasoning. Conflicts of interest influence our judgment in a similar manner. Sometimes, without realizing it, we make decisions regarding patients that are not in their best interest, but actually in our own best interest. These conflicts of interest are usually insidious. During our workshop, we'll spend some time on conflicts of interest and discuss ways to manage them. What is the definition of a conflict of interest? A simple definition is when professional judgment concerning the patient's welfare is unduly influenced by a secondary interest such as personal financial gain. We will discuss various examples in a minute. I'd like to emphasize that there are indeed situations in which the physician and patient are in conflict, such as when they cannot agree on a course of action. This is not a conflict of interest if the physician is acting in the patient's best interest and not in his or her own. To emphasize the distinction between conflict and conflict of interest, let's look at an example. Imagine a physician recommends dialysis to a patient who then refuses to start on dialysis. The physician's desire for the patient to be dialyzed seems to be in the patient's best interest. The patient needs dialysis. This would be an example of a conflict between physician and patient, one which will require serious persuasion on the part of the physician. This is not, however, a conflict of interest. But what if we find that the physician who recommends dialysis to the patient actually owns the dialysis center to which he is recommending that the patient attend and eventually derive income from? Well, now we're not so sure that the physician is acting in the patient's best interest. Does the patient really need dialysis? Or is the physician recommending dialysis to increase his dialysis center revenue? And if the patient does require dialysis, is this the best unit for the patient to attend? The physician appears to have a conflict of interest. The physician should recommend that the patient attend a different dialysis center. Over the years, we've collected many examples of conflicts of interest, either witnessed or experienced by medical students on the wards. We found that there are three potentially conflicted participants: students, physicians, and the healthcare institution itself. There are also various secondary interests identified by the students, which are industry sponsorship, research success, self-serving, either money gain or stature, and advancing education. Let's go over some specific examples. The most obvious conflict of interest is when a physician takes money from a drug or device company to use a particular drug or device. The physician will likely use that drug or device even though it may not be the best for the patient or the cheapest. How about pharma buying lunches for attendings and medical students? Does that set up a conflict of interest? Yes, it does. Years of research demonstrate the lasting influence of industry support on prescribing behavior. Physicians prescribe the lunch money supported drug before using a cheaper and perhaps more efficacious drug. Another place where conflicts of interest arise is when an investigator places his or her own desire to complete a research study over the patient's ultimate well-being. How about a physician who keeps a patient on a toxic and unnecessary drug because he wants to complete a research study of the drug, even though the patient no longer needs the drug? A reminder that these are actual examples that students observed on the wards in past years. So some physician actually did that. Another area where conflicts of interest arise is when a physician acts in a self-serving manner, either to save time when completing clinical tasks or enhance income. Consider the surgeon prioritizing private patients over clinic patients because of increased compensation with the private patients, regardless of the clinic patient's needs. Clearly, the patient's best interests are trumped by a desire for increased revenue. Sometimes students and physicians act to promote themselves, even though the quality of the patient care may be diminished. Consider the student who is unable to speak out when viewing a physician doing something incorrectly for fear of receiving a bad grade. Last but not least are the conflicts that arise in the educational space to promote education. Should a resident persuade a patient to get a myomectomy, which was not indicated because the resident had never done one before? Again, this is a real example. As mentioned, the above examples were those provided by the students in past workshops. Now it's your turn. Please bring to class one example of a conflict of interest and indicate the service, the role of the conflicted, and the secondary interest. Then we will discuss during the workshop. Let's move on to clinical informatics pearls. During this session, we're going to explore INYP, which is the COMC application developed by the Department of Biomedical Informatics that complements standard EHR, either Allscripts or Crown. It's our impression that there are a couple of tools that would be useful for third-year students, and the faculty, of course, which we will show you. We will also focus on how to avoid causing the hospital to pay a huge fine for a security breach. In 2010, COMC and NYP got fined a lot of money because of a breach. You don't want to be that person and have to explain to Dean Goldman why you lent your unsecured thumb drive with patient data to a person who's no longer a friend and is now posting patient information on the internet. Last, we thought we'd spend a few minutes on how to complete a data request for a scholarly project that you might be working on. In our discussion, we'll focus on what are the key data elements that you might need and how to get the data in a timely manner. We'd like you to complete a simple assignment to enable the discussion on privacy and security. Please try to recall a situation where your patient's privacy and security were compromised and offer a couple of ways to make certain that these events never happen again. We call these never events. So, off to conference. Here are your wonderful preceptors. For the Conflicts of Interest conference, the preceptors are David Rothman, who is a world authority on the topic and gave you a lecture in the first year Foundations course. Patrice Patalnik, who you know very well, who has served on various committees that investigate conflicts of interest. And Mary Jo Fink, your beloved teacher in Foundations, and who has taught other clinical reasoning topics. For the Clinical Informatics Pearls, the preceptors are Adler Perot, a PNS graduate now in our department, quite brilliant, and Ben Slovis, an emergency medicine resident, now doing a postdoctoral fellowship in the department, and moi. Looking forward to seeing you in the workshops. See you then, and remember they start at 8:30. Believe me, I hate getting up early as much as you do. I am not a surgeon. Thank you.